Greetings, everybody. We are starting our 10th intergenerational meeting. First, I want to put this on. I think it is on the screen. Today, we are having our 10th intergenerational meeting. It's on interactions with other health workers. But before going to that topic, we would like to say a few words about our dear friend who has recently passed away, Professor Parameshvara Deva. He had sent this small information about himself for a last year's meeting. I would like to share with you this message from WPA. It's on WPA's page. Norman
Dr. Joshkan, it doesn't go on. I don't see the following slides now.
Okay, sorry. Thank you. Thank you for warning me. This was the first slide. I think it's now seen. Is it?
Yes.
And this was about Dr. Deva. And this is the first page of WPA's message about Dr. Deva. Now I want to stop here. We have some words from Dr. Sartorius and some other things I would like to say, but we have distinguished colleagues among us. I would like to first ask Wolfgang Krall to say a few words about our dear colleague. You are mute. You are mute. We still can't hear you.
Oh, okay. Okay.
Oh, yes. Yeah, okay.
Now I see if I prepared a few slides, if I can show them. Do you see them? Do you see the slides?
Not yet.
No, oh, I don't know. Never mind. If it's not working, you know, I prepared some slides also with pictures of him. But then I will just talk a little bit. As a matter of fact, I met Professor Deva the first time when he was a young lecturer at the University of Malaya, and I was a volunteer doctor in Malaysia's largest hospital, Hospital Bahagia, with 2,800 patients. That was already in 1978. I was working quite far away. That at that time they had no autobahn, they had no highway, so it took almost a day to go to Kuala Lumpur, and I met him only occasionally. But I knew already about his work because in 1977 he started in this large hospital a model ward, how things should go, and that was important. Because a model how patients should be treated. Later, he came in 1991 to Germany to do a sabbatical, which I had organized for him at the University of Munich, at the same department where Emil Kraepelin was working before. And that was a start of a good friendship, because often he knew my whole family, my kids. He was with me for Christmas. He knew my mother, my brother, my sister, and so on. So we became very close friends. And in 1992, as a matter of fact, Deva and Dr. Subramaniam, they had asked me if I would help them in Malaysia. So I first became a lecturer and later associate professor at the University of Malaya, where Professor Deva was the head of the department. And I was always impressed by him. He did a lot of work in rehabilitation, and he was a founding member of the World Association of Psychosocial Rehabilitation. And he went to international meetings, but he came back on time and saw his patients. He never put work on us and said, do that for me, I'm internationally working. So that impressed me very much. And one of the things where he was very interested was medical education. And I think that is correct, because without good education, we will not make headways. And it's quite interesting. 3 days before he got his heart attack, he had asked me if I could send him. He was preparing a paper about medical education. And he wrote to me on the 23rd of March, "Dear Wolfgang, sorry to trouble you. I have to prepare a paper on medical education, and I wonder if you have the following information about the German medical course." And then on the 3rd of April, just 3 days before he had his heart attack, he wrote to me, "Many thanks, Wolfgang, for the detailed description of the medical course in Munich, Germany. So essentially, it's the same as when I was on sabbatical in 1991. Of course, he wrote more, but I don't want to go into detail. I just want to say a few words about his involvement in medical education as well as in psychosocial rehabilitation. He also, the last time I saw him in person was actually in 2016. In 2016, I was in September in Malaysia, and in 2016, in October, he came to Germany to give a talk about a talk about developing rehabilitation in developing countries. Actually, what is important about medical education, he wrote several books, also one about primary care psychiatry, and he called it the Lima way. Lima is 5 for in Malay, and he explained very well in simple language for trainees in psychiatry, and not only for residents, but also for lay people. And then what I think characterizes his personality very much, he also wrote another book, Daring to Change, a story of psychosocial rehabilitation in and for developing countries with low incomes. Yeah, I think I stop here. Of course, I could continue for the whole session because there are so many things we exchanged. And yeah, I feel very sad because we not only lost an eminent psychiatrist, but I lost a very dear friend. Okay, that's what I wanted to say.
Thank you very much, dear Wolfgang. We are planning to have a special session just on the educational aspects of his contributions together with David Barron. He is, as most of you know, our chair in section on psychiatry, medicine, and primary care, together with Association for Community Mental Health Promotion. I'm sure this month we will commemorate our dear friend. Would you like to say a few things, David, especially about him?
Yeah, no, I think, Wolfgang, I appreciate your personal I knew Professor Diva for probably the last 20 plus years when I first got involved with WPA. I think we can all share in the loss of someone who was committed to education, training the next generation. Even up till the end, he's been a valuable contributor, joining many of our calls that Belant has worked so tirelessly on to put together. I think many of our junior seat members had a chance to hear him and listen to him. So I'm very thankful for that. And all I want to say is I think all of us, we always mourn the loss of someone who had a passion for what they did and a passion that we all shared together. So I'm happy that we're going to be able to do something a bit more specific, but I think he would want us, knowing him the way we all knew him, to get on with the educational part of our program, because he was so dedicated to this throughout his career. Thank you very much. What about Rachel? Rachel, you also know him for a long time.
Thank you, Bülent. I think maybe not as well as some of the others knew him, but I first met him in '94, and when we were asked to go to a WHO meeting in Beijing, and was very impressed really by his sort of passion, enthusiasm, and knowledge of the realities in low and middle income countries. And then we coincided on several other missions. I remember to Iran and other various other places. And I guess I must have met him at WPA meetings as well. But I think for me, it was his major sort of passion and understanding about the importance of primary care that really stood out for me. And I think that will be sadly missed. He obviously knew an enormous amount about medical education, was a great teacher of the students and of primary care as well as the psychiatrists. Yes, his death has been a terrible shock to me, and I've always treasured all my interactions with him. Thank you for giving me the chance to say something.
Thank you very much. Before continuing to our today's meeting topic, I would like to share what Dr. Sartorius has sent to us. He is not with us today. I think it's seen, is it?
Yeah.
All right. Yeah, Dr. Sartorius said, sad news indeed. And he met him 40 years ago. At the time, he was working in Malaysia. And since then, we had occasional contacts. Throughout that time, I was impressed by the way in which he taught and used knowledge about psychiatry, making it a practical and useful part of medical practice. His work as consultant to WHO and his work in Fiji and elsewhere were remarkable by their fresh and down-to-earth approach. By the way, as Wolfgang gave examples to. By the way in which he raised the motivation of healthcare staff to help people with mental disorders and teaching them how to do it. And by his teaching young psychiatrists about the best ways to use their knowledge. We have not been in touch for some years, and then I met him again thanks to your initiative of the 10th of the month meetings, during which I was delighted to see that Professor Diva continued and developed the way of work which I admired many years ago. I shall not be present in your forthcoming meeting and have therefore written this note about Professor Deva's work, which I expect you will describe and discuss during your meeting. If you write to Professor Deva's family, please add my name to those who will sign the condolence. And here, a medical student from our seed group, Asmita Mishreka, says, Professor Deva always made a profound impact whenever he imparted wisdom during our meetings. His kind nature was evident in the way he shared his insight with us students. May he and his family find peace at this time. Before going into the colleagues among us, I would also like to share a few slides, 1 or 2 slides from the recent or one of the meetings where he had talked on good practices for education in mental health. It was on 29th of May last year. He always, as most of you know, underlined psychiatry is not only psychosis. Psychiatrists needs to do more in for PHC. These are in our YouTube channel. Anyone interested could have a look at them. And he was so kind indeed, thanking us in our own languages. I don't know how to read properly the other ones, but this was his attitude. So my last word about him is, may he rest in peace and continue enlightening mental health educators and students in healthcare with his wisdom. Now, who would like to say a few words? Cenan, Rojda, Sena, Nicholas, before we go to our main topic, which actually is related with his approach.
Maybe I can, thank you.
Please.
I knew Professor Double for the 1.5 years. It's a short time compared to yours, but I always admired his caring approach and kindness. In this very short time, we learned much from him, and I'm very sorry for our loss. May he rest in peace.
Thank you, Cenan. Nicholas, would you like to say a few words? He's from your country.
I've just realized I'm the only person from his home country, but just to let everyone know, David's with me now in two buildings away in my office. He's actually in my department right now. So we're both in Malaysia. So I've only known Professor Deva for about a year or so, but he's basically a luminary in the world of Malaysian psychiatry. I think, if I'm not mistaken, he set up the Malaysian Psychiatric Association, or if he didn't, he was one of the people who did so. He was the head of department at the University of Malaya, which is basically our Oxford or Cambridge, I suppose, and he ran the department there. And I would say that every single psychiatrist in Malaysia knows Professor Deva. And some of my very distinct memories of him were that he must be like late 70s, and about 5 years ago, so that he would be still in his early 70s, I saw him in our general hospital teaching medical students, and he would come every single day, bring a group of medical students, teach them, and I was thinking to myself, this guy is like, this is before I knew him professionally, and I was thinking, this lecturer of theirs is at least 50 years older than me, and he's there, and he's still teaching, and I'm so glad to see like his body may have aged, but his mind and his passion to teach still remain intact. And I guess he really made full use of the 70 odd years of life that he had. So anyway, thanks to Professor Deva, he has definitely built Malaysian psychiatry from nothing to something. And he was doing that until the final days of his life.
I'm sure he will continue inspiring us. Well, Rojda, Sena, our young colleagues, would you like to say anything?
I also want to say a few words. During the short time I knew him, thanks to our meetings here, he was a good educator who made a great effort to share what he knew with us. And it is very sad to lose such a value, really. And I wish patience to his family and loved ones.
Thank you, Rojda. Sena, would you like to say a few words as well before we go to the other topic?
I have met Professor Deva during our intergenerational meetings, and he was a great inspiration for all of us as we are students. May he rest in peace.
Okay. Now, today, we would run this meeting together with David as the moderators. Would you like to take on David, our main topic is interactions with other health professionals, which is a very special area. You are, I don't know how to express, but you are full of many things in that area, together with other friends here, of course.
Well, thank you, Bulan. And again, I'd like to engage more in dialogue, but it seems very fitting and that we actually made the plans for this before we knew of Professor Diva's passing. But this was truly a passion of his. And that's the interface of psychiatry with the rest of medicine, and particularly in primary care. And so I started my career as a consultation liaison psychiatrist. So I actually spent all my career working largely with non-psychiatrists, working in general medical hospitals and outpatient clinics. And I think one of the things that's very important for our students, for our SEED students, and I want to thank all of you for taking time to get on the call. And I'm going to pick on Nicholas because I'm here as his guest in this lovely city of Kota Kinabalu, and as a really, I'm just so honored to be a guest here with them for the next month. But we don't teach a lot about how do we best and most effectively interact with our non-psychiatric colleagues. And I know Rachel has spent a good deal of her career as really a world leader in this area. Wolfgang, we don't know each other quite so well, but I don't know of a good senior psychiatrist who hasn't somehow learned that fine art of communication. We learn how to communicate with our patients. We learn how to communicate, hopefully a little bit better with their families, but we oftentimes don't get enough formal training or experience in interacting with our non-medical colleagues. And the problem that can arise is when you're in psychiatry, we learn to speak the way psychiatrists speak to one another. We use, as we say in the States, sometimes psychobabble. We have our own language that we've developed. And we assume when we say certain things that our colleagues understand that. So when Bulat and I talked about this, we thought it would be a very important role for certainly our SEED students, hopefully going into psychiatry, that one of the ways we deal with stigma is not just dealing with community and public image. These are all very important. This is not to diminish how important it is to get out there into the community, to deal with public figures. But a lot of what we do with stigma actually comes from within the field of medicine. So we need to present ourselves to our colleagues that we are in fact physicians who subspecialize in the area of behavioral and mental health. And how we communicate with them, I think, can go a very long way in addressing the issues of stigma, that mental health is an important part of health. And we've been talking about this a great deal. And the way we can represent this is when we get an opportunity to meet with our non-psychiatric colleagues, is that we can really show we are here to help them in the care of our combined patients working together. So I think one of the things, I'm going to mention just one or two, and then I want to throw it open to our other senior members, and then I want to throw it open to you as the students for what your perception is. But the most important thing I'd like you to take away from this session is that it is very important that we are representing our profession of psychiatry every time we interact with a primary care doctor or an internist or a surgeon. And it's important that we listen to them. We listen to what they're asking for us. As a CL psychiatrist, my first question would always be when someone asks for a consult, how can I help you with this case? What are you looking for? How can we work together on this? So I think we have to speak the language of physicians. We have to remember that we are proud physicians, that we all went through medical school, and that we want to learn from each other and share our perspective on how important mental health is to physical health, not just well-being, certainly is that, quality of life, but to physical health. And in fact, the data that's coming out is I find it very interesting, but not surprising that, the microbiome directly connected to the brain, the heart directly connected to the brain at a biological level, not at a mystical or spiritual level. So we have a wonderful opportunity, and it will be your generation of physicians the seed students on the call to take this to the next level, to make sure that we're representing our specialties, but really our patients who have medical as well as psychiatric illnesses. And the way we communicate with them will have a great deal to do with how we're viewed. So just a few opening comments. I'd like to maybe get some comments from our three senior members on the call. And then the most important comments are those from the students and from Nicholas, who's kind of a little bit beyond an early career, but what your perceptions are, what your thoughts are, and how we can learn together. Rachel, you want to pick it up? I just see it. You're next on my list here. So,
thank you, David. That was very helpful and lovely introduction to the issue. And I quite agree that stigma is kind of rife about mental illness amongst our medical colleagues. And it's one of our tasks is to address it, really. And it's one of our opportunities, because we have a lot of opportunity to get at it. So I think there's kind of at least two sorts of situations, really. One, when you're directly asked to go and see somebody on the medical wards who might have a sort of psychiatric aspect to the case. But the other is just the opportunistic interactions that you have over the lunch table or the coffee table and so on. And I think both are important. And in relation to seeing the clinical case, obviously it's as important to be as helpful as you possibly can, and also to take the opportunity to explain as far as you can what you think is happening. So all that time will be well spent, and take the time to kind of write a decent kind of review in the case notes, but also take the time to talk to the medical team as well about what you think is going on. I think the opportunistic moments in the canteen are also very important. And when I was a liaison psychiatrist, I used to make a point of going to have lunch with my medical colleagues. It was always quite hard work. And sometimes I had to steel myself to do it. But it was always very rewarding. And it is a major opportunity to, it's an educational moment really all the time, just to talk about mental health issues and to try and share concepts, because often it's easy to talk past each other because you're coming from such different perspectives. And so it's helpful to just have, be able to have brief, simple conversations about what mental health is, what mental illness is. The prevalence, the causes and the consequences. And yes, this exciting research about, we've always known about the association between physical and mental health in both directions. But now there's all this research both about the microbiome and about cytokines and so on, inflammation being at the root of both physical and mental problems. So, yeah, so the research context is extraordinarily interesting now. So I think we should take these opportunities. That's my one message. Second message, I think, to really make sure that you're on the same page in relation to your concepts, so you're not talking past each other. And that may take a while. And thirdly, not to give up. I always used to say to my team, it's the drip drip effect. You know, when water's falling off a ceiling in a cave and it forms a stalactite, you know, or a stalagmite, kind of both ways. And it takes kind of aeons, but you get there in the end. And so I think don't be put off if you have a difficult conversation. You have to keep going back and back. And I used to feel that it would take 3 years to get somewhere. The first year, they're kind of arguing with you. The second year, they ask questions. And the third year, it's their idea. And then you know you've won. So I think just be persistent in the nicest possible way.
Excellent points, Rachel. I couldn't agree more. I probably did more consultation and liaison work in the cafeteria or just walking down the hall and say, oh, I've got this patient who's got, and I'm going to ask Nicholas in a minute to talk because I've learned here he does everything. In the morning, he comes in early, he's sweeping the floors, then he goes and cooks lunch for the patients, then he's giving examinations to all the medical students, then he's writing the research grants. So he's used to representing how hardworking psychiatrists are, but your points are so well taken, is that we are representing, and sometimes I once had, I thought it was an insult, but I took it as a compliment. One of my internist friends said to me, well, you can't be a psychiatrist, you're just a normal guy. And I said, all psychiatrists are normal guys and gals. You just don't know enough of us yet. So Rachel, thank you for those points. Exactly what my 40-year experience has been. Maybe if we can get Wolfgang and Bulan to make some, Bulan, please.
Excuse me, I'm afraid I missed the second point Rachel mentioned. Could you repeat that, please? You counted 3.
Right, was it, what were the points you did get, Bülent?
One was drip effect.
Yes.
One.
Keep going. Yes.
Keep going, yes.
Yes.
And the first one, to have contacts with others, continuous contacts, wherever possible.
Yes, so to be opportunistic, you know, and you talk to people in the canteen, at lunch and at coffee and so on. So take your opportunities where you find them. It's not just around the clinical case. It's when you meet people casually as well, at parties, lunches, and so on. You can talk mental health. They're all kind of educational, teachable moments, as one of my colleagues has said, in the nicest possible way. And the third point was really to make sure you share concepts, so you understand where they're coming from. And as David was saying, speak in their language, because otherwise, if you can't go from where they are at the moment, you won't get so far.
Excellent points. So Wolfgang, would you want to share some thoughts as one of the senior members on our group?
Yeah, well, as a matter of fact, there was one paper I wrote together with Prof. Deva, and that was Psychiatric Education of Medical Students in a Developing Country. Actually, it was written in German, Psychiatrische Ausbildung von Medizinstudenten in einem Entwicklungsland. And we published that in 1996. And there we mentioned that the psychiatric education in Malaysia was much, much better than in Germany at Kraplin's famous university in Munich. And what I learned, actually, we had 3 months of psychological medicine or psychiatry. And I learned a lot of things. For example, I learned you do not teach only in the psychiatric ward, but what we also did was already liaison psychiatry for the students. The students, for 1 month, they stayed in the ward. The other months, they were distributed to different other wards: surgery, internal medicine, orthopedics, gynecology, and so on. And the task of the students was to find out where are patients with psychological problems. And that was told by the nurses. They said, oh, this person always looks anxious. This person is not eating well. This person is not sleeping well, and so on. And then the students had to take a case history and then present the case history to us, the lecturers. So that was what I learned. We need to teach not only psychiatry in psychiatric wards, but we have to do that in general wards. Okay, so this was what I experienced and what I learned in Malaysia. Then what you already mentioned, what I think makes a lot of sense is a non-formal education of our colleagues, but we learn as well, and that is a cafeteria. Of course, it's different if you are working in a large mental hospital, then you don't have many other colleagues besides psychiatrists, but in general hospitals, you have. And I have different fields where I work, for example, also in addiction medicine. And we had a ward to detoxify, as well as a day clinic and a rehabilitation program in a general hospital, in one of the largest hospitals in Munich. And of course, to a general hospital, there are a lot of emergencies, and a lot of people with addiction problems come. Usually people with alcohol problems. And that is where I agree completely with David. My task was, I was a senior consultant, I was heading that unit. In the morning, I would go to my colleagues in the emergency unit, ask, how can we help you? And they were very happy that we were there, because to work with addicted people and alcoholics is not that easy. So we had a very good understanding. And of course, when I had patients with medical problems, there was never, ever a problem to discuss that with my medical colleagues. The same was true for surgery and other fields. Then I want to mention, we have to, or I'm involved in Germany in outpatient addiction rehabilitation. And that is not run by doctors, but it's run by social workers, psychologists. And therefore, you have to talk, you have to speak their language. There, the doctor is not the boss. I'm a team member. So this helped me a lot. Okay, that's what I wanted to contribute. Thank you very much.
Thank you so much, Wolfgang. I know I'd like to ask Bulan and Nicholas. I know Nicholas has to catch a flight. He does basically everything here. I'm so impressed. I think he's cloned. I actually think there are 2 or 3 different Nicholases, and he's just fooling me. But I know he's got to jump on a flight to run a major meeting over in Kuala Lumpur across the South China Sea. But Nicholas, could you share your perspective as someone who was actually fairly early career, but doing the work of many senior psychiatrists at your university?
Thanks, David. And I'm just, before we continue, just in case people didn't catch it, I'm really, really pleased to have David become our first visiting consultant to do his sabbatical in our little university on Borneo. So hopefully anyone else of you who want to come to Borneo, more than happy to welcome you. You get to stay in a little house with occasionally running water by a river. You may not get a shower, and but you get to see a lot of stuff, sit by the marina. I think Dave has mentioned a few times I'm an early career psychiatrist, so I'd like to bring home a very important point. The people who are going to become members of other professions are the students I teach. It's really difficult. I'm sorry to say, but it's really difficult to change an older person. And I speak for myself as a 36-year-old person whose friends, my colleagues, are all in the late 30s, and it's really difficult to change the attitudes of people when they've already been in the profession, they're already entrenched. So when I teach my medical students, we've come up with this. I drill into them from the first day they come, because all of them think psychiatry is pseudoscience. Like, you turn up, this person's depressed, this person's anxious, that's about it. You're done. You don't need to have a full understanding of it. I teach them differently that I'm trying to reconceptualize everything my students do as, this person doesn't come with schizophrenia, but this person presents with psychosis. It could be organic, it could be substance related, it could be some medication to give to the patient, could be all sorts of various things. It could, in fact, be a psychiatric illness. And your job as a doctor in training is to figure out what the other causes could be and find out whether they are there. If they are not there, as is the case in 90% of the time, then fair enough, it's schizophrenia. And I'm training them to do the same thing with presented with depressive symptoms, presented with a manic episode, presented with features of anxiety, and figure out what is the underlying cause. Because it's really important that I put into them that multidisciplinary thought in their heads, that psychiatric presentations have multidisciplinary causes. And if they learn from day one until the last day they exit our posting that psychosis is schizophrenia, depressive symptoms are depression, mania, well, obviously that's bipolar. And you know what, as a side note, let's do a few tests to exclude some other possibilities. But I'm really trying to turn it backwards on the head and make them think at the beginning, you need to think of all these other causes first. Because when you grow up to be good physicians or good surgeons or good whatever, when someone presents with a psychiatric, what is thought to be a psychiatric complaint, then they will immediately, hopefully, flash back to when they were 23 and they'll think to themselves, could this have a surgical component to it? Could this be caused by one of many medical illnesses that I didn't think about? And I hope they carry that with them all their lives. The second thing we teach them is that all doctors need communication skills, because all of them, my medical students are all gonna grow up not becoming psychiatrists. If they all become psychiatrists, I'll be a bit worried. It means there's something really rotten in the state of all the other professions around, that they think our job's so much better. It's probably not. In fact, it's probably fairly hard. But I want them to all develop this kind of very communication skills, which is why in our program, I'm not sure what other programs do, we teach them to do motivational interviewing. We teach everyone mindfulness skills, because that's just wellness. You can teach people wellness from the first day. We teach everyone how to do recovery plans, how to do relapse plans, how to do wellness plans, and we teach them to do it as part of an examinable skill, because we all know that if it's not an examinable skill, no one bothers to learn how to do psychoeducation properly. I had a really interesting comment from a student 2 weeks ago when I taught them the psychoeducation module. They were like, "Oh, doctor, could we do this for hypertension?" And I said, "You can do it for anything. You can do education for anything using the same psychoeducational model that we do. Why not?" So I really hope that we start them right, because when they get to my age, let alone at other people's ages, it's really difficult to retrospectively put in everything, because it's like building a house, isn't it? If you build the house right the first time round, then you don't have to keep renovating it. And I'm faced with the problem of having to constantly try to retrofit all my colleagues think in other professions. Yeah. So that's about it. And thanks again, once again, thanks Dave for coming. I hope the rest of you come one day too.
Thank you, Nick. Well, Bulan, we've known each other for so many years. My Turkish brother, and I've observed Bulan, and his communication skills are extraordinary. Whether it's with politicians or other psychiatrists, he has this wonderful style that he makes you feel comfortable. He makes you feel concerned, that he really cares about what you're saying. And you know, as Rachel really mentioned, you know, this is an important part of what we do. I'll never forget, we did a survey of a large number of primary care physicians a number of years ago when I was at another university. And their biggest complaint when they sent a patient to psychiatry for a consult is the psychiatrist, they don't get back to me. Or they get back to me and they write a report that makes no sense to me. They never even asked me what I wanted them to look at. So I think Bulan is the perfect person, and then we'll throw it over to our students for their comments and questions to share his many years of wisdom and his interpersonal style that has allowed him to be just a great, great communicator with not only his colleagues in other fields, but certainly the students. So Bulan, please.
Well, I'm embarrassed, David, with all your words. I had in mind to underline a few things about other health professionals. I mean, they may be, of course, our physician colleagues, but we have other health workers as well. So they are also very important. But while my dear friends were talking, I recalled a memory from 1977. When I was an intern. In Turkey, we call interns the last year medical students, not the first year as in the United States, as far as I know. But last year medical students work in different places. And one of them is, of course, emergency unit. I had good contact with our psychiatry teachers, and I had asked them if they would allow us to have discussions with patients in the emergency unit, and then come up to psychiatry department and discuss it together with the teachers and clerkship students. Orhan Öztürk, one of our major administrators, teachers, he said, well, why not? Go ahead. And every clerkship time, which was 3 weeks, we had some interviews with patients in the emergency unit. But the interviews were how they felt, nothing about their illness. How do you feel? What is your need? What are your thoughts about these going on things? Of course, you can imagine emergency units. And they were a bit surprised. What were we doing there and why we were there? One of the patients wanted a song from the radio. He thought we were coming from radio because no one else would come and ask with such people. And we, after collecting, of course, not recording, at that time I didn't have my camera, with taking notes, we would go up to the department and discuss all the patients' words, what the students felt. This was indeed a very good way of starting. As Nicholas says, it's not easy to change the style of people in my age or those near to my age, but doing such things with medical students really helps. I wanted to underline this. Thank you, David.
Thank you, Gulan. Well, now I think we have about 12, 15 minutes, so we've got 3 students, so we'd really love to hear your thoughts about this. Do you feel you're getting adequately trained? Either questions or comments. So I'll just go in the order I see on my screens. It looks like Rosa, you're first, so please share your thoughts, but I want to hear from all of our students on the call today, please.
Okay, thank you for giving the word to me. And I want to say, yeah, it is understandable when it comes to your position, because as we are medical students now, I mean, the education, of course, our psychiatry sessions together with our teachers were perfect. We had a good inspiration, but when it comes to other non-psychiatric professors, sometimes this made us, I mean, for example, I will give a concrete example to this. For example, we were learning pseudo seizures, I mean, the psychogenic non-epileptic seizures in neurology. And then our professor said, okay, these are, okay, we will learn now how to compare if it is a real seizure or not, if it's a pseudo seizure. So yeah, they taught us this, how to make it, how to exclude the other one. But then they said they behaved like the other one was not really a disease. I mean, I got this feeling of the other part was a bit worthless when it comes to medicine. And yeah, in a way, other professors, I felt, yeah, psychiatry is a big thing, and I was also interested in, and I got this inspiration from our psychiatry education. But when it comes to other things, it was, I mean, yeah, we had in our paper this psychiatric questioning as well when we went to wards, in general wards. But then we could not really ask this psychiatric, I mean, the mental health status to patients. It was like a diagnosis coming from exclusion of other diseases, for example. We did not really question. Me, myself, I questioned it as well, but when it comes to other colleagues and our other medical students, if they are not really interested in this, it was hard to get into it. And I also remember at the stigma session, Dr. Deva said, in the curriculum, more common and should know conditions can be taught rather than rarer diseases such as psychosis, for example, which also causes these prejudices. Maybe it was a bit missing in our education. I mean, we could not have the general perspective, how to combine how mental health issues can have an effect on other, I mean, the physical conditions. Yeah, it could be more like, it could be given more detailed, or I don't know, maybe we can avoid the other subjects to go deeper into details, but we can give the general aspect more and more. So the medical students will understand how to have a good approach to patient as a whole in mental health, and then also in physical perspective. Then they will go to in any branches later. They will be a specialist later, but they will have in mind this approach, how to question, for example, mental health status. So I think it was a problem starting from medical education, really, because we could not really maybe combine both of them. It was coming from maybe the missing part of psychiatry education as well, but also other professors' approaches were affecting us.
Thank you. So Sinan, I'm sorry you're at the bottom here. That's the problem with Zoom if you get on the time. But I know you are probably closer to medical school than a few of us on the call. But now, as a psychiatrist in your university, I wonder if you could share your thoughts with us, and then we want to make sure that we have time for Sina to share her thoughts as well. But Sinan, please.
Thank you, Professor Baron. Maybe I can make a small contribution about this communication issue. When I was a resident in our consultation psychiatry department, I realized that some of the consultations for inpatients at our other departments are needed because a problem occurred between the patient and the healthcare system or our medical staff. So I realized that a simple rule, when we go to a consultation, asking our colleague, the physician or the nurse or the other healthcare personnel, to introduce us to the patient is very important. Or just simply asking the patient, were you aware that a psychiatrist will come and see you today? If we don't ask this, maybe we are thinking that we are talking to patient, taking history, doing a psychiatric examination, but at that time, maybe the patient is thinking, patient thinks, why this man has come to speak to me? Am I crazy, or why did they need to psychiatric consultation? So asking our colleagues to introduce us, or asking the patient, were you aware that I will come, is very important. And one other thing that asking our colleagues their opinion about the patients, what was the problem? Do you have anything to say about this patient? Did you have a problem with him or her? This makes our colleagues understand the patient better, and even changes their approach to the patient. So I totally agree, and this communication issue with our colleagues from other branches.
Excellent, excellent point. I couldn't agree with you more. Nothing worse than you go in to talk to a patient, and all of a sudden you're asking things like, you're not asking where it hurts or this, and then they get offended. So I think your point is really, really well taken. And a part I think every consultation liaison psychiatrist learns, and it kind of taps into Rachel's point. So thank you for that. Sina, please share with us your perspective, your thoughts, questions, and comments as someone who's right in the beginning of this.
Actually, I have a question. You talked about experience-based models like conversation in cafeteria or so. Is it more important than theoretical lectures to given the other healthcare professionals, both psychiatry, or is it more important like psychiatry lectures which are given to students?
Well, we can share, I'll share my own bias. We all know there are good lectures and bad lectures. A good lecture might inspire people. A bad lecture might turn them off. I actually believe that in my career, 40 plus years now, like Bulan, I feel I've probably done more to address this issue, as Rachel said, in a casual conversation. We used to call them, curbside consults in the hallway, in the dining halls, because that's a less formal way. And we can relate to our colleagues, as people, where lectures sometimes they're not so interested. So I'm not saying lectures aren't important. I think they're very important. Sharing data so people know that there is a scientific basis. There's evidence base behind what we do. It's not just our thoughts and feelings, in a kind of a non-scientific way. But I believe some of the things that we don't get as much training in and are equally important is that ability to have a physician respect what we are, what we can do, appreciate what we can offer to them in a way that is not necessarily always in a formal lecture. So I would say a kind of a combination, but I think both are necessary. So maybe a quick response from the others on the call, see what their feelings are. And then I want you to have some more time to address your points. Anybody else want to address that?
Well, I don't think it's either or. I think you've got to do both. As a student, you've got to go to your lectures. But the conversations are also important.
And it's a good comment. You can sometimes use the conversation to underscore the issues in the lecture and vice versa. There can be an added cumulative effect where one can reinforce the other. So I couldn't agree more with Rachel. Both are important. And we as psychiatrists, we make our living in communicating and listening well and reading people. We should be very good at this. Sometimes we are, sometimes not so good. The better we are at doing this, the more effective we'll be. So I completely agree. And anyone else have any quick responses to Sina? And then I'd like her to get on and share some more of her thoughts. Bless you, Nicholas. I heard you 2 buildings away. So Sina, please, that very good question, but any other thoughts or comments you'd like to share?
As a student, I see stigma around myself in students, and I think to change it is implementation of psychiatry in other courses. Like sometimes there are surgery, internal medicine, and everything but not psychiatry, and it causes stigma because psychiatry is different than the others. It causes it. So seeing psychiatry in other lectures is, I think, helpful for us.
Well, for sure. I wonder if you have any thoughts on how we can address this. And another thought is, I'm sure Rachel and I know Bouland and I'm sure Sinan and Wolfgang know as well, is we need to make ourselves available. I would always go and present at grand rounds in OBGYN because I did women's mental health for a while, or in orthopedics or neurosurgery. We need to go and become a part of that. I'm very proud of the fact that I've been invited, as many of my colleagues, to present at major medical meetings, not just psychiatric meetings. So I think we have to get out there and share with our colleagues what it is that we have to offer and to let them know that we have an evidence-based science and we can help them in the care of their patients, understanding that. So again, do you have any thoughts yourself as a medical student going through training now? Or Rocha, and really anyone on the call. We've got a small intimate call today.
Yeah, for me, it was a combination. Like, first of all, maybe with your communications, as you told, with your communication, you can give a perspective to other teachers, first of all. Then they will try to give this perspective later to us as students. And it would be very important for me because what I was trying to explain was that really, because I could not have this value of psychiatry from other specialists. It was only coming from psychiatrists. And when it comes to other things, they said, okay, this is a psychiatric issue, so you will deal with it somewhere else. Like, it was not really given from other professors. So that was my...
Yeah, we need to find, it's not a psychiatric, it's a healthcare issue. That emotional issues are part of healthcare. There is no health without mental health. So we need to help redefine. We need you as our junior members and as students to say, these are not siloed psychiatric. This is a component of health and well-being. And as we integrate those more together, then maybe we can start to change that culture. So thank you. Sina, I know Dulan, are we finished on the top of the hour? We're almost out of time.
We have, we may go to 90 minutes.
Okay. I didn't know we had extra time. Well, thank you. So, Sina, how about some other thoughts? Since you were you were kind of last on the list, but very important perspectives.
Elizabeth, I'm just in a Zoom. I'll be back.
Sina, any other comments or thoughts?
Me?
Yeah.
Oh, sorry. I thought it was Jenan. I'm sorry. Yes, I agree, Rojda, and I think it is a common problem as well.
David, can I just say something?
Please, please.
Arising from what's been said, it does sound to me as if some of the teaching the students are experiencing is not biopsychosocial, as it were. And I think that's the thing that we want to aim for in all of us, really, is to approach every consultation thinking biologically, psychologically, and socially simultaneously, whether the person is in a medical ward or a psychiatric ward, because we know that physical and mental illness is so intertwined, and social factors affect both and the consequences of both as well. So we need to come at things in that framework. And it does sound as if some of your teaching isn't doing that, which is a shame. And I have to say that during my time as a liaison psychiatrist, which was only 3 years, but during that time, I never came across a purely psychiatric problem on a medical ward. They were always biopsychosocial. And often the consultants would refer people to me saying, Rachel, this is psychiatric, you know, take him or her away off my hands. And I would go into it with the team and they would always be wrong. There would always be something physical there as well. And one of the people who I've never forgotten, she was a woman in her 40s who was complaining of terrible abdominal pain. She was in agony and she had been abused by her father through until adult life, sexually abused. So if anybody kind of, as it were, justified abdominal pain, this was the woman for psychosocial reasons. And even I was convinced, but a month later, she died of undiagnosed bowel cancer. So this is the message, really. When they try and tell you something is purely psychiatric on a medical ward, it probably isn't. Of course, psychological factors will be important. They always are in every case. But usually it's that they're missing some serious underlying physical condition. So I can't tell you the number of things that physical things I've diagnosed as a psychiatrist.
Yeah, absolutely. Very good. Well, I think we've had a chance to hear from everyone. We do have a few more minutes, although I'm sure we could all use the extra time. But anybody have any other thoughts they'd like to share? Please, Bulan.
Yeah. Please.
Okay. Actually, I would like to make a comment. Rachel, you are absolutely right. But what happens also is on psychiatric wards, we have people who have physical illness, and that is overlooked by psychiatrists. This is a very big problem as I see it. And that is also today, a lot of psychiatrists think they do not have to make a proper physical examination. And I think this is very, very wrong. You have to do both. We are doctors. We are not psychologists. I mean, psychologists, it's different. They don't do physical examinations. But a psychiatrist has to take a physical examination. And then we do not overlook physical illness in psychiatric wards. That is a comment I wanted to make.
That's an excellent point, Wolfgang. And there's very good data to demonstrate that as well. In fact, the mentally ill are more likely to have diseases that end up in medical. So it's an excellent point. Bulan, please, you had a comment.
Yeah, I was planning to talk about the concept of learning together, which is spread out in your talks. For 2 or 3 years, we had some meetings together with family physicians or GPs, let me say. That's a problem. That was a problem indeed. All the GPs were claiming that they were taught all the time. At whatever age they were taught by some specialists, especially when we talk about mental health issues. Psychiatrists would teach them. But in our program, we said learning together. We have a lot to learn from GPs or family physicians. And I was trying to spare some time from our guests as GPs to share their experiences with our young medical students, because they had a lot to tell them, other than the specialists in the hospital in different branches teaching them their own views. So this was something which I wanted to underline as well. David, you are right. We do not have to go until 90 minutes. If all is all, that would be fine, of course. Thanks, everybody.
Anybody want any final thoughts or comments or questions? I know it's 15 hours difference from my colleagues in Los Angeles to where I'm sitting here in Sabah.
I wanted to suggest, Bülent and David, given the issues that are coming up, whether we could take a future session to discuss the relationship between physical and mental illness, whether that would be helpful for the students.
Absolutely. That's really the title of the section, right? We're talking about psychiatry, medicine, and primary care. So, Rachel, I think absolutely that's critical to, that's the foundation of what this section is all about. And certainly your many years of experience in there. So without question, I think we can do that moving forward. Great suggestion. Anybody else have any thoughts or questions or comments? Yes, Rajda.
I also wanted to say that, yeah, I guess one of you mentioned it, but for example, when we were in the internal medicine ward, there were people coming, there were many physicians who attended the healthcare of a certain, patient. But when for example, if it is a geriatric patient over 65, then a geriatric professor comes. But it is also, when a patient is, for example, is there for more than 1 week, it is also a threat for mental health, I guess, staying in the hospital, in the wards. But I did not see really anyone coming from psychiatry department to consult the patient, for example. So we could not really see how they make the consultation for the patient. We did not attend this thing together. It was not integrated there. So maybe psychiatrists also can come and show us as a student there, show us how to have this story, how to see the risks this patient is under. So we can see it better there, I guess.
Very good point. Demonstration, seeing something, like they say, a picture's worth 1,000 words mentality. So I think that's an excellent thought, and we need to try to bring that in. Any other thoughts? I know Nicholas had to run to catch a flight, but any other thoughts before we move on with our days? Well, let me thank all of you. I know we're all very busy. It's the end of the summer, beginning of the school year for most of us, and it's not easy with the time differences, but I really appreciate it. I really appreciate all the work Bülent puts into setting these together. And Rachel, that'll for sure be one of our important sessions moving forward, because that really is at the heart of what we're trying to do. I hope everyone is safe and well. Enjoy the rest of your summer. Stay cool. I know it's been pretty hot pretty much around the globe. I know it's been very hot and humid here in Malaysia. But thank you all very much. Be well, be safe, and we'll see each other soon.